Welcome to ATCM, the Emergency Medicine channel. Shall I? Presenting the case of a 3-year-old boy who presented to ER with complaints of intermittent colicky abdominal pain since 2 days associated with 1 episode of vomiting. On PAD triangle assessment, appearance, child was crying and was restless. On breathing, there was no increased work of breathing. Circulation part, child had normal colors and extremities were pink in color. On primary airway was patent, there was no pulling of secretions. On breathing, child had a respiratory rate of 28 per minute with a saturation of 99%. Air entry was bilaterally equal. On circulation, pulse rate was 110 per minute with a BP of 100/65 mmHg. Disability wise, child was irritable and crying. Child was moving all 4 limbs. At this time, since child was having pain, we had given analgesics. We had given injection PCM 15 milligrams per kg. Child weight was 12.7 kg, so we had given injection of 180 mg. Coming to the exposure part, child was febrile and was having a GRBS of 98. On sample history, 3-year-old boy presented to ER with complaints of intermittent episodes of colicky abdominal pain since last 2 days. Initially, the pain was of less severity and gradually it worsened. In between the episodes, child was calm, and during episodes, child was irritable and crying. Child also had 1 episode of vomiting on the day of presentation. There was no history of loose stools or constipation, no history of blood in stools, there was no history of fever, no history of dysuria, no history of new food intake, no history of any trauma, no history of any recent vaccination, or no history of any lesions over the body.
Why no history of recent new food intake, you told?
Because during the in childhood period, when new foods are introduced, many children develop allergic reactions to the food and have abdominal symptoms.
Correct. Basically, anaphylaxis. It's a form of anaphylaxis the child can present. Since this child, they will be having loose stools, vomiting, and colicky abdominal pain.
Coming to the allergic history, no allergic history to any medicines, and medication history, child is not on any routine medications. Past history, no relevant medical history.
There is an important thing in children you have to mention about
immunization history.
Yes, so in previous medication or past history, you have to mention whether child is immunized till date or not. That's very important. Okay, because if not immunized, we have to think about those diseases presenting with these symptoms.
Patient was immunized up till the age. Coming to the examination part, on child was irritable and crying. On inspection, there was no visible lesions or any scars. On palpation, abdomen was soft. There was a vague mass in the right side of the abdomen, and there was tenderness on palpation, but we couldn't elicit more because the child was crying and not cooperative to our examination. And then since the history of the child was about giving history of intermittent colicky pain, and since we have got a mass in the right side of the abdomen, and considering the age group of the child, we were considering it to be we have kept the differential diagnosis.
What were your differential diagnosis?
Initially, since pain and vomiting, 1 episode of vomiting there, we had suspected any simple gastroenteritis it could be. Then considering the age group, it can be induciception. Then Meckel's diverticulum can be considered. Then mesenteric lymphadenitis can be considered. Then in case of female children, you have to suspect ovarian torsion or any ovarian cyst rupture.
At that age, ovarian cyst is highly unlikely, right? And if ovarian cyst is there, it's highly likely to be evaluated further. It's not like a natural occurrence. More
ovarian torsion can be considered. Then in male children, undescended testis has to be considered, torsion testis has to be considered. Then in any infection, that is perforation peritonitis should be considered if the child is unstable, vitals are unstable.
What else?
Then any abuse should be suspected. Then any trauma history should be asked to the parents.
Blunt trauma to the abdomen, abuse history. should always be looked into. History you won't get, but you have to look for signs of abuse.
Any
What are the
aberrations, any fracture, like fractures of different age groups ages can be seen in
rib
chronic
fractures?
abuse.
In children, rib fracture is very rare. So if you have a rib fracture, you should suspect abuse or high impact trauma. You should suspect contusions. You should look for different ages of contusion. You will have not just a contusion, multiple contusions of varying degree of evolution. You can find out. Then anything else?
Any incarcerated hernia also.
Yes,
Hernial
hernias.
orifices should be looked into.
Especially internal hernias can present even at that childhood age. Femoral hernias and umbilical hernias are unlikely at this age group, but possible, especially umbilical hernia. Femoral hernia is very unlikely, especially for an active child. But internal hernias are there. So if you are not finding any other examination findings, internal hernia is a possibility.
Then UTI also can be there.
Correct, UTI. If it is a much more younger child, like 1 year, 2-year-old child, what else can be there? Urinary complication as such. Very unlikely to be in 3-year-old. By that time, patient would have already presented in 1 year, 1 to 2 years. Yes, VUJ valve causing obstruction, causing pyelonephritis, viral-uterinophrosis, pyelonephritis, cystitis, all those things we can suspect. Okay, so these were your differential diagnosis. Okay, now coming to examination, right? So coming to examination, what and all you got a mass lesion with any guarding rigidity.
Guarding rigidity was not there. Tenderness was there. Then we couldn't elicit more because child was not at all cooperative.
So very unlikely to have any perforation as such, isn't it? Since no real guarding is there. Then important questions were constipation,
loose stools, any loose stool, any blood in stools were there.
Correct. Blood in stool is very important here. And loose stool episodes. Patient is having?
Patient was not having any loose stools or blood in stools. Patient was only complaining of pain and 1 episode of vomiting.
Okay. So in this patient, with this examination finding, what is your primary diagnosis now?
Since we have got a mass and intermittent episodes of colicky pain, we had suspected it to be an induciception, considering the age group also.
Most likely area?
Usually right side, right hypochondrium pain will be there. Right side of the abdomen we get the pain and the mass.
What type of induciception are we?
Ileocolic.
Either it can be ileocolic or?
Ileojejunal can be there, colojejunal can be there, jejunojejunal can be there.
Jejunal or cecojejunal is likely, right?
Most common is ileocolic.
Ileocolic. Okay. So what did you further?
So initially we have kept the child on Nilper oral, and then since the child was kept on Nilper oral, we had started him on fluids. So usually we give fluids based on the holiday Sagar formula, that is daily requirement. So for the first 10 kgs we give 100 ml per kg. The next 10 kg we give 50 ml per kg, and the rest of the weight we give 20 ml per kg. So since the weight of the child was around 13 kgs, we had calculated and it came to be as 1150 ml over 24 hours.
Correct. Over 24 hours you give. So 1150 divided by 24.
24 hours. So we have got around 50 ml per hour, 47 ml per hour it was. Okay. So we have started the child on half DNS of 50 ml per hour.
Why did you start half DNS?
Because since we are keeping Nilper oral, both sugars also we wanted to supplement.
It's very important to supplement sugars in pediatrics because they are very prone for hypoglycemia. Especially if patient is having dehydration features, they are very likely to develop hypoglycemia as such. So hypoglycemia correction is very important rather than in adults. Adults we have much better glycogen store, so very unlikely we go into that much hypoglycemia. Okay.
Then for pain, we had given the child injection PCM 180 milligrams. We have given as IV since patient was giving a history of vomiting and couldn't take orally. We had given IV for the patient, and then we had gone with the investigation part. So we had taken a USG abdomen plus pelvis for the child, and the USG abdomen showed long segment ileocolic intussusception with multiple enlarged lymph nodes within. So we came to a diagnosis of intussusception. And coming to the management of the intussusception, usually if there are no features of perforation peritonitis and the vitals are stable, then we can go ahead with the reduction of the intussusception, usual pneumatic or hydrostatic reduction. So in this child, we had gone with pneumatic reduction. After the pneumatic reduction, child was asymptomatic. We could attain the reduction within the first attempt.
Initially, we keep the patient NPO,
NPO.
hydration, and then take for pneumatic or hydrostatic reduction. Okay. How do you do pneumatic and hydrostatic reductions?
Usually, Follies will be after keeping NPO and proper analgesia, Follies will be inserted, and then we'll give the pressures either for pneumatic air.
Foley's catheter is inserted. Where?
Follies catheter will be inserted through the rectum.
Anus. That is, you are saying Foley's is inserted. Foley's is not meant to be inserted in anus. No, so
okay.
mention that part.
Okay. It will be inserted into rectum, and then air. If it is pneumatic reduction, then we will be giving air. In some institutions, CO2 is also used nowadays for pneumatic reduction. In case of hydrostatic reduction, it can be saline or any contrast material. Usually nowadays contrast is not preferred because in case if a perforation happens during the procedure, it might cause more reactions. So saline is most preferred in case of hydrostatic reduction. And then we'll be visualizing it in under ultrasound or fluoroscopic visualization will be done.
Fluoroscopic most commonly.
And during the visualization, we'll be able to see that whichever intussuscepted area, air passing and getting reduced. Dilatation we'll be able to see.
Yeah, okay. Okay, so that is the, that's what you do in this. If this patient presented you with abdominal pain, right? Think that this patient had these symptoms for one day. That's what you told. What if this patient was having these symptoms for past couple of days, associated with severe nausea, 2-3 episodes of vomiting, 2-3. What do you think? Is constipation most common or loose stools very common?
In intussusception?
In children.
Most common loose stools will be.
Most common is loose stools, not constipation. Hardly children will go into constipation or obstipation due to intussusception. There are other conditions, but in intussusception. So this patient is having a 2-3 days of history, but intermittent pain. So parents didn't think much serious, and nausea, decreased food intake, and but loose stools, around 4 or 5 episodes of loose stools is persisting. That is how patient is presenting to you. What are the most important red flags that you will think about?
Patients' vitals should be first checked to know because of multiple episodes of loose stool. We should rule out dehydration.
We assess with PAT triangle, right? Yeah. So what in PAT triangle will you check for?
In appearance, color, that we have to check for the refill, capillary refill time should be checked. Color
PAT
of the
triangle you check
appearance
with the
of
patient
the
or away from patient?
away from the patient.
So capillary refill time is not in PAT. PAT triangle is when you are approaching the patient, you are mentally making an idea how the patient is going to be. Okay.
The appearance of the patient, the child will be sick looking child in appearance, and then in circulation the color of the child should be noted, whether the child is pale or not. which are the features of like patient has gone into dehydration?
You should look for shock.
Shock.
Right. Dehydration, shock is what you should look for. Dehydration reason?
Because of multiple episodes of loose stools,
Loose stools and
vomiting if there is
nil per oral.
nil.
Patient most probably will not take food and water. So decrease intake, increase output will cause patient to be dehydrated. So what are the clinical features of dehydration?
Skin turgor you should look for, skin pinching and look. Then you should look for the tongue. Then eyes.
In PAT itself. It doesn't matter. Fine.
You should look for the eyes, where the sunken eyes are there. Skin turgidity should be looked.
So we have mild, moderate, severe dehydration, right? So what are the features of mild dehydration?
In mild, the skin, when you pinch the skin, it will go fast. There will be no tongue will be moist only. Then child will be drinking, will be able to drink. Thirst will be there, but child will be able to drink water. Like will be able to drink.
Child will always be able to drink, but thirst will be there. Child will ask for fluids or will be will be receptive towards fluids. Oral fluids. Then tears will be there. Mucosal drying usually will not be there. And urine output will be preserved. Child will be active. Alert, isn't it? What is moderate dehydration?
Moderate child becomes more alert. Skin turgidity will.
Is it alert or something else? Not drowsy, irritable. Irritable, crying, irritable child.
Then skin on pinching will go slowly only. Then tongue will be mucosal dryness will start to appear in the child. Then urine output will be reduced in the child. Thirst will be there for the child in moderate also.
Thirst will be there. Child will come ask for water, but patient will also have tachycardia and tachypnea features will be there. Skin will be dried out. What is severe?
In severe, eyes will be sunken, child will be very alert, child will be...
As dehydration worsens, child will become more alert.
Lethargic, child will be very lethargic, drowsy.
Lethargy, can go into severe coma, even can cause seizures. Why seizures? Why dehydration should cause seizure?
Hypoglycemia.
As we told, hypoglycemia.
Then skin will on pinching will take time to go. Then full features of mucosal dryness will be there. Urine output will be very much reduced.
Will be nil. In severe, it will be nil. Okay. So these are the features of dehydration. The dehydration should be looked into. So in such a patient, like this kind of patient, how do you proceed?
We have to
severe dehydration. Think that is severe dehydration.
We should supplement the daily requirement, and with every loose stools we have to give 10 ml per kg fluids should be given for the child.
You told it's severe dehydration, right? How do you treat severe dehydration? You are an emergency physician.
IV fluids can be given. Bolus dose can be given to 20 ml per kg dose should be given.
Not 20 ml per kg. You will look for signs of shock.
Okay.
Say the things. You are going to look for shock. In severe dehydration, what you have to look for is hypovolemic shock. Hypovolemic shock is the most common type of shock in pediatric age group. And there is septic shock. In this patient, if at all presenting to you with intussusception, your first thing is going to be hypovolemic shock. So hypovolemia should be corrected before you go and manage other shocks. Okay. In adults, there can be multiple shocks coexisting, but in children, unless you correct hypovolemic shock, no other pharmacological management will act. Okay. So hypovolemic correction is very important. So question is, are you dealing with severe dehydration or are you dealing with hypovolemic shock? How will you know that?
Vitals, tachypnea, tachycardia will be there.
In severe dehydration, tachypnea, tachycardia will be there now. What else?
Hypotension.
Hypotension. So what is the age appropriate BP for this patient?
For this child, usually age 2 into age plus 70 is the systolic BP. If below that BP falls, it is considered as hypotension in children.
So
in this child, it was 70 mmHg. Systolic BP should be more than 70.
yeah,
If below 70, it is considered to be hypotension.
hypotension. So first and foremost thing is looking for hypotension. What else? Shock is same in all humans. What you do for adults?
Hypotension, widening of pulse pressure, tachycardia, CR elevation of CRT, monitor the urine output.
അഡൽസിന് ഏതൊക്കെയാണ് നോക്കുന്നത്? വന്നപ്പോൾ തൊട്ട് എന്താ ചെയ്യുന്നത്? അഡൽസിന് വേറെ ഒന്നും നോക്കൂല.
Lactate elevation.
Lactate elevation. See, patient may have mild dehydration also. Question is, are we looking for shock or not? So if shock is there, patient still may not have hypotension. We have already covered it, right? So there is a compensated shock and a non-compensated shock. Non-compensated shock patient will be in hypotension. That is very clear. But what if BP is like this patient, 70 millimeter systolic BP is there. But what if patient's peripheries are cold, clammy, peripheral pulses are very feeble, urine output is reduced, BP is stable because there is sympathetic supplies inside, right? BP can be stable, heart rate can be elevated, cardiac output may be preserved, but since peripheral perfusion is low, lactate will be elevated. So you have to say lactate elevation here. As emergency physicians, your job is to look for shock. Okay, shock is same in adults and children. Even management is nearly the same, but you should look for that. Okay, so shock you will look for. If shock is there, how will you manage?
You have to if it is hypovolemic shock, then bolus fluid should be given.
How much?
20 ml per kg will be initially
How
given.
long?
Bolus can be given for the initially bolus should be given, and then daily requirements also should be given for the child.
So 20 ml per kg you are given for severe dehydration patient. BP is still low. Peripheries are still cold, tachycardia, mild improvement. Earlier, for example, let's say a heart rate of a 3-year-old child. So 135, abnormal, right? What is the normal heart rate for 3-year-old?
Up to 120.
Up to 120 is normal. So 135 clearly tachycardic. You gave 20 ml per kg. So this is, what is the kg of the patient?
12.3.
12. So 12 into 20, 250. Let's say 250 ml you gave. Heart rate from 135 come down to 130. Respiratory rate is still the same. What else? BP is still 70-40.
Fluid is, first of all, you get fluids, then if patient is not.
See, give fluid 20 ml per kg.
Start with vasopressors.
Noradrenaline. Unlike in adults, children, fluid boluses can be given multiple times. That's the important thing. Adults, we give 20 ml per kg, then once patient is not improving, we start on iron drops. That's because in adults, cardiac dysfunction is highly common. In children, cardiac dysfunction is very rare. Unless there is a septic myocarditis or a patient is already a known case of cardiac failure, we really don't see cardiogenic shock in children. Okay, so if cardiogenic shock in children, it's mostly sepsis induced or acidosis induced. So you can give multiple doses. 20 ml per kg, you can give up to 3 times. Give up to. So 20 ml per kg bolus. If patient is improving, that is fluid receptive. So you have to get a improvement in heart rate. You have to get a improvement in urine output, and then you can say patient is fluid receptive. Then you can give another 20 ml per kg, and one more time, up to 3 20 ml per kg boluses can be given. In over 1 to 1.5 hours you can give. So around 60 ml per kg, okay? Because dehydration is the most problematic in children. So correction of dehydration is very important. And after like 3 boluses only you have to think about ionotropes syndrome. because as we told, pharmacological intervention in adults will not improve the child unless dehydration is corrected. Okay? And along with it, when you give fluids, you have to think about sugar. Hypoglycemia should be taken care into. And like in adults, you can check the IVC. You are not looking for IVC values, you are looking whether IVC is collapsed or not. So that you can do. Ideally, with these boluses patients, fluid status, that is IVC should be filling up, urine output should improve, peripheral pulses should improve, peripheral vasculature improvement will cause warmth or normalization of temperature to the peripheries, and child's sensorium will become better. So improvement in sensorium is one of the best things you can see in these patients. So after this fluid boluses, how will you continue fluids? Like you gave like 40 ml per kg, 20, double you gave. Patient sensorium improved, patient from drowsiness has improved to a bit more irritant, it's crying a bit, and urine output is slowly bringing up. So Foley's insertion is required. You have to insert Foley's, then only you can monitor the output. So all pediatric child group, if it is severe hypotension is there or shock is there, Foley's should be inserted. Okay. So slowly improving. So you decided to continue fluid therapy. How will you give fluids?
Maintenance doses can be given for the child.
The formula that you told.
Sugar formula.
Anything else?
Then, like if the patient is continuously having loose stools and vomiting after each episode, also you should give additional fluids.
So not only the maintenance fluid should be put for each episode of loose stools or vomiting, preferably 50 to 75 ml extra should be given to the patient, because or else ongoing fluid loss will not be covered or corrected or covered. Okay. What else? That is fluid management. So if you want to start inotropes, what are the inotropes you will prefer here? Think that intussusception has perforated and patient has gone into shock. Okay, that is guarding rigidity. What will you do? You have given fluids, you have corrected hypovolemia, your IVC is now better, your peripheries are improved, but patient is still having rapid 30 pulse and shock features are still there. How do you manage? Now what is the cause of shock?
Now septic shock.
Septic shock. You should suspect septic shock. Perforation itself will cause third space shift of fluids, isn't it? So that's why initial fluid therapy is very important. But once that is given, if patient still is in shock, you should suspect septic shock. How will you manage?
Inotrope should be started.
What inotrope?
Noradrenaline can be started.
Noradrenaline can be given. Like in adults, it's the same, norad, vaso, artery, dopa. It's not very different, but what is preferred? Norad, sure, I am not saying norad is wrong or norad should not be started, but in children, well, like in adults, will you start dopamine?
For septic shock, we prefer noradrenaline.
No. In children, is dopamine a bad drug? Dopamine bad or not? Simple question, yes or no? In adults, why don't you prefer dopamine? In adults, why don't you prefer dopamine?
Septic shock initially vasodilatation.
Vasodilator.
Dopamine has vasoconstriction. Dopamine has vasoconstriction, no?
Heart rate.
Huh.
Heart rate.
Huh. Is heart rate the problem or something else the problem? Uncontrolled heart rate the problem. What is that called as?
Because the chrono.
Arrhythmia risk. Say this. Arrhythmic risk. Okay. Dopamine arrhythmic risk. So, in adults, already in sepsis, there will be tachycardia, increased heart rate. So, dopamine can cause arrhythmogenic risk. In pediatric children, like less than 4 3-year-old children. What is a good heart rate for a pediatric child? Like 2-year-old, 1-year-old. What is the heart rate for 1-year-old?
120s, 90s to 120s.
Yeah. So, in 2-year-old, even 3-year-old, is dopamine a bad drug?
No.
Their heart rate is already elevated. You are more concerned about bradycardia. When do you start CPR in pediatrics?
Less than 100.
Less than
60.
100 alla.
60.
Less than 60. Less than 100 if you start CPR, many children you will have to start. You give atropine less than 100. Bradycardia is less than 100 in children. Less than 90, well, less than 100 as well as less, but basically if it goes less than 90, you should take it as bradycardia and you should look for symptoms of symptomatic bradycardia or not. Less than 60 is CPR. So you have to understand, in adults you don't do CPR at 60, right? So because your heart rate is much more lower side, children is much more higher side. So dopamine can be given early. Dopamine will cause vasoconstriction, will improve cardiac contractility, will improve cardiac pumping capacity also. So stroke volume and vasoconstriction will be there. Especially in sepsis, dopamine can be given in pediatric age group. It's not like it's like adults, it's not like you should not start. In adults, we don't start, right? Unless there is bradycardia with hypotension, we never start dopamine. Children, it's not like that. You can still start dopamine. Dopamine is set of choice. But preferred is not now. In adults, dopa is not at all preferred. There it's still preferred. You can give. If you suspect a sepsis-induced cardiac dysfunction, you can definitely give. ഓഫൊന്നും ചെയ്യണ്ട. എന്തായാലും ഇത് ഇൻ്റർനെറ്റിൽ കയറാൻ പോണില്ല. വന്ന വഴിക്ക് നിൻ്റെ മകൻ നിനക്ക് അവിടെ റീൽ കണ്ടോണ്ടിരിക്കുക. ഇന്ന് ഞാൻ തിരിഞ്ഞപ്പോൾ തെറി വിളിക്കാത്തത് ഞാൻ വേണ്ടാന്ന് വിചാരിച്ചാൽ അപ്പോഴേക്ക് വേറെ ഒരുത്ത വന്നിട്ട് ഇവിടെ അവൻ്റെ മൊബൈൽ ചാർജ് ചെയ്യാൻ കൂടി ഉണ്ടാക്കി. അതുകൊണ്ട് ഇതെന്തായാലും ഇനി കയറൂല. സാറിനോട് പറഞ്ഞാൽ മതി, സാർ അതിൻ്റെ അകത്ത് ഇഷ്ടംപോലെ ഡിസ്റ്റർബൻസ് വന്നു അതുകൊണ്ട് ഇട്ടിട്ടില്ല എന്ന്. ഇനി അത് വെറുതെ ഇനി കുത്തിപ്പിടിക്കാൻ വേണ്ടി പോകണ്ട. So dopamine is still a good drug in pediatrics. You will still see critical care specialists starting dopamine in sepsis patients. So in sepsis, not dehydration. So that's what hypovolemia is always fluid therapy. There is no inotropes. So 20 ml per kg I gave. I start inotropes should not be done in pediatrics. Pediatrics will not improve. You have to give fluids. So if it is hemorrhagic shock, one of the people it's better to give whole blood transfusion is in pediatrics because volume. So whole blood transfusion is one of the one age group of people in which you prefer whole blood transfusion is pediatric age group, pediatric trauma. So fluid correction in sepsis, dopa or noradrenaline you can start. Vasopressin should be only used at the end because severe vasoconstriction, there will be significant acral necrosis in pediatric age group and all. You don't prefer that. So it will be norad, dopa, then vasos. You have to understand. So the huge difference from adults in what to start. Okay. What are the needles for pediatrics, IV access?
22.
22 is the large gauge IV access. Basically, your 18 gauge is 22 needle. So if you are putting a EJV for a child, 22 is the needle that you take. And you are putting cubital for the child, 24 and 26 as the peripheries. Usually we put 24 everywhere, but 26 is available. Anesthesia has it.
26 violet.
26 violet. 25 ആണ് തോന്നുന്നു വയലറ്റ്. 26 25 ആണ് തോന്നുന്നു വയലറ്റ്. ഇല്ല, ഓറഞ്ച് അഡൽസിനാണ്. ഓറഞ്ച് 14 ഗേജ് ആണ്. ഗ്രേ 16 ഗേജ് ആണ്. 14 ഗേജ് ആണ് ഓറഞ്ച് അഡൽസിനാണ്. ഇത് വയലറ്റ് ആണെന്നാണ് തോന്നുന്നത് 25 gauge. So anesthesia has it. We don't keep it because it's very thin and very short. Total length of the needle will be this much only. But that is actually very good to put on foot. Okay. IV access. You don't get IV access, like severe dehydration patient. You don't have IV access. Your staff has tried IV access. You are trying IV access. You checked IV, this thing, what, ultrasound. Not at all getting. What will you do?
Nauseous.
Where will you prick?
tubercle, crust, sternum,
Where will you prick?
സ്ഥാനത്തിൻ്റെ അവിടെ പ്രയ്ക്കാം, പക്ഷെ പ്രയ്ക്ക് ചെയ്യാറില്ല.
സ്റ്റേണത്തിൻ്റെ അവിടെ prick ചെയ്യാം, prick ചെയ്യാറില്ല. It doesn't look good. അതാണ്, doesn't look good. That is the reason. Otherwise, there is no problem in that.
ഇല്ല, ക്രസ്റ്റിൽ
Tibial
ട്യൂബ്രോസ്
tuberosity or tubercle. Below tibial tuberosity. Because there is tibial growth plate above. So if you prick there, patient can go into growth plate necrosis. So there will be decreased growth. Limb lengthening, shortening can be there. So you palpate tibial tuberosity and below it is where you prick. How will you prick? What will you use?
ബോൺ സ്പൈനൽ ബോൺ മാരോ
You have bone marrow, you have this thing, what actual Indrosius needles are there, Indrosius gun is there. Indrosius gun is the best thing. It is a single shot, it will penetrate, you don't have to worry, patient's pain is also much better control, because other thing you have to drill. But if it is not there, what will you use? Bone marrow needle. You should use a bone marrow needle. How will you know you are inside Indrosius? You are in the space.
fatty,
Marrow contents. Where will you see?
needle, hospital,
Bone marrow needle. Bone marrow needle is made of steel.
and the
So to remove trocar and aspirate, you should know you are in the space. No, how will you know?
give away.
Sudden freeway will be there. So you will be exerting pressure to penetrate the bone. The moment bone is penetrated, you will certainly feel a giveaway. This is not the giveaway you get in LP and all. This is clear giveaway. You will never miss. You will certainly feel there is no resistance. Okay? That is very important, because you miss that, you may puncture the bone and come out. Okay? So very controlled movements. You have to stabilize the knee, stabilize the foot. Someone has to hold it down, and you are doing controlled twisting motion. And at one point, you will certainly feel a giveaway. That is the area. Stop there, remove the stillet, take a 5cc syringe. You can put maybe 1 or 2 ml also, doesn't matter, and aspirate. If nothing is coming, don't think that you are not in space. You can be. Okay? Just put that 1 to 2 ml into the needle, push into the needle, and then aspirate. Because sometimes, since patient is severely dehydrated, the marrow contents may not come out. So you may not know you are in the space. So you have to push in the fluid and then aspirate. You will get the marrow contents coming up. So fatty contents, blood will be coming up. Once it comes, you can correct. How long will you use Indrosius? Maximum 24 hours. So that means the moment you put Indrosius, you have to correct aggressively fluids and then try for a proper cannula. You should not keep it more than 24 hours. Okay. How will you stabilize the Indrosius needle? You have to splint the leg. You have to splint the leg in extended knee position and tie it down. Like what we do to the wrist, no? Tie it down. What and all you can give in Indrosius line? Everything can be given. Everything. Including ionotropes you can give. Okay? Okay. When will you put Indrosius line?
evidence.
True. How will you know IV lines are not there? Like, how long will you try for IV lines? expert person 3 times trying, failing, and there is no EJV, you should try for this thing. Since we have ultrasound, we can try for ultrasound. But usually it will be difficult in children. It's not like in adults. Severe hypertension will collapse almost all veins. So even the ultrasound probe pressure itself will collapse the veins. We can always put in direct IJV, but like we tell, no, it's not a what to say, continuous measure. You can like you don't have introversions, you don't get anything. Obviously, you are going to put into direct IJV and push in the fluids. So somehow you will get a vein and remove the IJV. Obviously, if you don't get anything, the IJV cannulation can be done. But you should not tell that to anyone. When someone asks you, what will you do? Don't say, I will put in IJV. It's always introversions. You understand? Or central line. It's never IJV. Okay?